Assalamu alaikum and good evening, everybody. For those of you who are brave enough to be here today, thank you ever so much. On behalf of Shaukat Khanum, I would like to welcome you to the final session on breast cancer, and this is going to be centered basically around breast cancer surgery. I would like to invite our guests and speakers to be here. Professor Farooq Afzal, very, very special thank you for being here today. He is the principal of Services Institute of Medical School and is the chief of surgery these days at Services Hospital. He has a very, very keen interest in education as such and has been instrumental in the formulation of guidelines for cancer treatment in general, which are going to be circulated and implemented now nationwide. So it's an honor for us to have you here with us today. The rest of the speakers I will introduce as we go along. The first talk is going to be by Dr. Rufina Somro, who comes to us all the way from Karachi. Professor Rufina Somro has been instrumental and has worked really, really hard with the College of Physicians and Surgeons Breast Surgery Fellowship. And that's how my contact with her has been the most in the last couple of years. So Dr. Rufina will speak to us about how we changed our routine practice during the COVID era for the treatment of breast cancer and breast cancer surgery. Dr. Rufina, welcome.
Assalamu alaikum. I would like to thank the organizers for inviting me here for this prestigious conference. And I'm going to talk about breast conservation surgery in the pandemic era. And in the next 15 minutes, I'll talk about impact of COVID-19 on breast cancer diagnosis treatment, effect of delaying the treatment, and what is the status of breast conservation surgery in Pakistan, and what we have learned from this. So during COVID-19 pandemic, all over the globe, breast surgeons were faced to prioritize breast surgery in order to comply with the potential shortage of hospital beds, ICU beds and ventilators, and to minimize patients' contact in the hospital and thereby to reduce the risk of acquiring COVID-19. And to do that prioritization, various international bodies combined together and they formed a breast cancer consortium, and they divided, prioritized into priority A, where there was acute threat to life. B means they require treatment during the pandemic, and C, where the treatment can be delayed beyond the pandemic. But during all this, the risk of disease progression had to be balanced with the risk of acquiring COVID-19. And the basic principles of breast cancer management during the pandemic were: do what you can normally do based on the local conditions. Endocrine therapy and radiation were considered relatively safe. And in certain situations, it is okay to delay the treatment. And chemotherapy regimes preferably can be chosen, which has less risk and require less visits to the hospital. And obviously, the local COVID situation has to be taken into consideration. So during COVID-19, various units managed to operate and prioritize breast cancer management depending upon the capacity and the resource availability. And by far, the breast reduction surgeries, immediate reconstruction, and oncoplastic procedures when screening was put on hold during pandemic. And I feel in Pakistan, this ratio is very low. Maybe it is less than 2%, if I'm right. And we know that mammographic screening has been proven to decrease mortality in women who are regularly screened as compared to the other population. And in Korean study, it was shown that delaying cancer treatment beyond 12 weeks is associated with adverse outcome. And in UK, they did the modeling studies and they said not even 12, even 2 weeks got delay has an adverse effect. And in Netherlands, they also believed that if we delay the treatment, it will have an adverse outcome because they found during the COVID that early stage breast cancer diagnosis was little less. But if you see this big numbers from American study, and you say that they were trying to see the DCIS and early stage cancer T1, T2, N0, this is what we expect to see on screening. And this noticed that even delay of 120 days did not affect the overall survival in this group. So in Turkey, they said they noticed the number of cancers dropped during the pandemic. Their breast conservation surgeries also dropped, but the TNM was not affected. And they probably opted more for breast cancer surgery rather than giving neoadjuvant therapy. And during the first pandemic phase, the breast conservation rate went down, but then gradually improved. So they postulated that the tumor stage is not affected in intermittent pandemics, especially if the duration of the wave is very short. We must take into consideration that breast cancer patients have been noticed to have more depression, major or minor, as compared to the rest of the population. And depression confers worse outcomes, including non-adherence to the treatment and decreased, they have increased mortality. So when we are delaying the treatment, I think that effect of treatment delay on these patients of group must be calculated. So what were the surgical options? The breast conservation surgery with radiation therapy is considered the gold standard for early cancer. It is most commonly performed procedures with good cosmetic results and less post-operative pain and quicker recovery. So what was the breast conservation surgery rates in various world? In Scotland, they tried to do more oncoplastic procedures, but their breast conservation rates were still low. The same was in India and in Spain, where they had a dedicated COVID-free units for breast cancer management, and they were doing everything. Even then, the breast conservation rates were low. So was in Pakistan. But these breast conservation rates were low only during the acute phases of pandemic, preferably in the first, more commonly in the first phase. Then it started to improve and it came back to their normal rate of breast conservation in many centers. When we look at our institute's data, though the number of cancer surgeries have been increasing, but we look at our data in the year 2020, our breast cancer surgery rate has dropped down significantly. And obviously breast conservation rate fell down proportionately. But if we look at it in terms of percentage, we noticed that our breast conservation rate was in fact higher during the pandemic. And if we look at monthly from the date of the start of pandemic, we were affected by the first wave of pandemic and in the subsequent pandemic waves also, as compared to the Turkish studies. And then we slowly and gradually, the rates were higher in between the relatively easier time periods of the pandemic. And our breast conservation rates were also went up, but then it came down to afterward, it normalized after the pandemic, first and second phases of pandemic. What happened worldwide after delaying these cancer detection? In San Diego, they noticed that stage 1 breast cancer patients fell down from 63 to 51%, and number of stage 4 patients went up. In other studies also, there were higher number of stage 3 and stage 4 patients, whereas in some other studies like Netherlands and other European countries, there was no change in the TNM after the pandemic. In our data, we did not find any rise in the stage 3 lesions. In fact, this was little low, and same was a thing in the stage 4 cancers. Things were totally different in India, where I think pandemic affected them badly. After neoadjuvant chemotherapy, normal their surgery time was within 6 weeks. But in pandemic, their operation time delay was more than 85 days. This was the mean delay. And more than 50% of the patients, while waiting for this time, the disease progressed, so they needed to give more neoadjuvant therapy to bring them to operable positions. And with this diagnostic delay, their patients presented with more advanced stage, requiring more neoadjuvant therapy and more mastectomies. And with this delay, 1/5 of the patients had a progression of the disease, and obviously that probably would affect their overall survival. But on the other hand, things were totally different in British Columbia, where things improved. And they noticed their wait time from the core biopsy to surgery and to the oncological management, which was 58 days, is improved to 28 days. And this they were able to do because of more use of regional anesthesia and then the same day surgery techniques. So their regional anesthesia increased significantly, and so was the same discharge policy, same day discharge. And they concluded that if we do the day case surgery, improve more use of telemedicine and improve anesthesia technique, this can be probably recommended even beyond the pandemic. And in Rome, they calculated the day case cost of breast cancer surgery and breast conservation surgery. They noticed that the cost is almost 50% less if the breast conservation surgery is done on the daycare basis. I would like to briefly touch what is the status of breast conservation surgery in Pakistan when we are talking about it. When breast conservation surgery is considered the gold standard worldwide for early breast cancer stage, and there are this n number of studies and many more, they suggest that breast conservation surgery with radiotherapy is not even equivalent, but even better than mastectomy. And I will just quote this study comprising of 50,000 patients, where they proved that overall survival and breast cancer specific survival is better than mastectomy in breast conservation surgery group, as seen in this Kaplan-Meier curves. And they said that more extensive breast surgery does not appear to save any lives. In Pakistan, we have a varying rate of breast conservation surgery, and still mastectomy is as the most commonly used procedure. And apologize me if I've not taken this here data from the government institutes, because I did not have reliable access to it. And I've just taken the data from the institute that are recognized for training by CPSP, and their breast conservation rate varies from 30 to 50%. And in Shaukat, Khanum, I'm told it is 65 to 70%. So what are the factors for this low breast conservation rates in Pakistan? And I've come up with few reasons, and I'm sure with this audience around, probably there may be many more. One of the thing is our patients present with advanced stage. That is the thing seen in our institutes. And when I looked at the other data from various sources from Pakistan, various institutes, stage 1 breast conservation, stage 1 presentation is less than 10%. In our institute, though the rate has shown an increasing trend of breast conservation, but it is still less than 10%, stage 1 less than 10%. We do lack trained breast surgeons. As pointed out, breast surgery as a specialty for second fellowship is a new at CPSP. We have 11 approved supervisors and 6 training centers. But that does not mean that these are the only. We have many more trained, qualified breast surgeons who are doing an excellent work. But generally, if the general surgeons, when they breast surgery, I think mastectomies is still their commonly performed procedures. I think we lack teamwork, and MDTs is the backbone of any cancer management, and so for breast surgery, breast cancer, where we take decisions about neoadjuvant therapy, how do we localize tumors, what is the extent of disease, the pathological details, and what can be the various surgical options that can be done to conserve breast. And we closely collaborate with our oncological colleagues. And if we lack that, I think breast conservation surgery rates would be affected. We definitely have are lacking in, I think, radiotherapy facilities. And in most of the institutes, especially government settings, wait time for radiotherapy can be 6 months. I face that, and I'm sure many others face that women even wanting to have breast conservation surgery, they still succumb to the decisions of the family members who believe that mastectomy is better than a breast conservation. And this is not only with the family members, there are alternate therapists and even some of the doctors who probably discourage women to have breast conservation surgery done when it can be easily done in that select population of the women. There are financial constraints, and they are more so in private hospitals, because generally private hospitals tend to charge little more for breast conservation surgery, more so if there are oncoplastic techniques and maybe perforator flaps done. And if margins come out positive and they require another surgery, that is an additional burden, and radiotherapy also costs significantly. What about socioeconomic status? When there are, we know the status in Pakistan, even a country like Sweden, where the government takes the responsibility for providing equal health opportunities to everyone, there also poor socioeconomic status, they present with the advanced stage, and somehow their education level is still low as compared to the elite population. So their mastectomy rates are higher in low socioeconomic groups. And then if there are no radiotherapy facilities in the nearby area, they have to travel to the other area. So there is travel and accommodation cost added to the radiation cost, which probably forces them to have breast mastectomy. So I think I would like to conclude from this American poet quote that only thing that is normally more painful than learning from experience is not learning from it. So what we have learned, that do the maximum possible to treat cancer patients, keeping safety and resource availability. I think multidisciplinary meetings are the backbones, and they must carry on, whether in face or on line. And we try to do breast conservation surgery as much as we can. And if we can really change it to the day case, that will be very nice. We do have guidelines, but we need to have national guidelines for breast cancer management, and in routine use and in conditions like pandemic. We need to optimize our chemotherapy regimens to minimize burdens and side effects in patients in situations like pandemic. And we have to think of other improving radiation facilities and including accelerated radiation therapies. Thank you so much for patient listening.
Thank you, Dr. Rufina. Next, I'm going to invite Abida Sattar. Abida and I have had a close association on the few visits that I've paid to Karachi, and she's been here and on a few meetings that we've attended together. I asked Abida to touch upon my favorite area in the treatment of breast cancer, which is the management of the axilla. I've always found it very challenging. It seems to be the most important region, and Abda's just going to shed some light on that for us. Abida Sattar is Associate Professor of Surgery, and she's the Chief of Breast Surgery at Aga Khan University. Thank you for being here with us, Abida.
Amna, thank you very much for that kind introduction, and thank you, Asad Parvez, and you for the honor of the podium. I was totally engrossed in Dr. Rufina's talk. I completely forgot that I actually had to speak. So there has been a paradigm shift in management of axillary surgery, and I think that's what really keeps it very interesting for most of us. And the goal of all these paradigm shifts really has been to decrease the morbidity without compromising oncologic surgery. And we've been doing that by de-escalating surgery in both node negative as well as node positive disease. However, increasing use of neoadjuvant chemotherapy has made some surgical decision-making somewhat challenging. So there is a small subgroup of patients who probably could be spared any axillary surgery whatsoever. And typically patients with advanced stage serious comorbidities, pure DCIS undergoing breast conservation, and those with very small tumors that have hormone positive disease or those undergoing prophylactic mastectomy could probably be spared any axillary staging. So Amna asked me to speak on early and advanced breast cancer related axillary management, but for the sake of the discussion and using the speaker's prerogative, I decided to divide it into upfront axillary surgery versus axillary surgery after post-neoadjuvant chemotherapy, because I thought it might be more relevant to the current era. So it's well established that in clinically node-negative disease, if the patient qualifies for upfront breast surgery, sentinel lymph node now is well established as a safe procedure. A clinically negative axilla being defined as a negative exam or a negative ultrasound or a negative biopsy in case of those lymph nodes that were initially considered to be suspicious. And there is no debate that a negative sentinel lymph node in this setting, you do not need any additional axillary treatment. And traditionally, we've done an axillary lymph node dissection for a positive sentinel lymph node with all its associated morbidity. We also know that the incidence of finding additional disease on an axillary clearance after a positive sentinel lymph node really depends on the disease burden identified in that sentinel lymph node. And based on that, for isolated tumor cells and for micrometastatic disease, we do not do an axillary dissection. For those who have macrometastatic disease, i.e. a MET that is greater than 2 millimeters in size, we end up doing an axillary dissection. And when we do that, we know that 40% of the time, we do not find any additional disease in that axillary lymph node dissection specimen, which means that potentially 40% of the time, we are doing unnecessary surgery. Based on NSABP B4 data, comparing the total mastectomy patients to the radical mastectomy patients, we know that in total mastectomy with the unaddressed axilla, we potentially left disease behind in approximately 40% of patients. However, only half of them actually had an axillary recurrence at 10 years. And please bear in mind that this was in an era when systemic therapy was not as advanced and not all patients receive systemic therapy. From recent times, doing sentinel lymph node biopsy, from all these studies, we know that there is a significant false positive rate. A false negative rate of a sentinel lymph node, which means we are potentially leaving disease behind in about 10% of patients. But the local recurrence rates are less than 1%. So that raises the question, do we have to do an axillary lymph node dissection in every single patient that has a positive sentinel lymph node? So this question was partly answered in this very famous Z11 study by Giuliano, And I think the results of that study are very significant because it allowed omission of axillary lymph node dissection in some of the sentinel lymph node positive patients if they met the selection criteria. And the criteria were that they should be small tumors, ideally T1 to T2. All of them were clinically negative. They tolerated up to 2 sentinel lymph nodes that were positive. All patients had breast conserving surgery and received whole breast radiation. Up to 90% of them had been treated with systemic therapy. And comparing the two arms, which is those who received a completion axillary dissection versus who got no additional axillary treatment, we know that 27% of the time in those with an untreated axilla, we potentially left disease behind. However, the local recurrence rate, once again, was less than 1%. Now that was strictly for breast conserving surgery. Now what about mastectomy? If there is a clinically negative axilla and a positive sentinel lymph node, there's very limited data for the mastectomy patients. The AMAROS trial, which did include some mastectomy patients, was essentially conducted to compare axillary radiation to axillary lymph node dissection for locoregional control. And comparing the two modalities, both had very low local recurrence rates with a slightly lower rate in axillary lymph node dissection, but in exchange, a slightly higher risk of lymphedema. So in the AMAROS trial, 2 to 3 sentinel lymph nodes positive could omit an axillary lymph node dissection in favor of axillary radiation with slightly decreased morbidity. However, I would argue when there is no indication for post-mastectomy radiation, perhaps we can do an axillary lymph node dissection to completely spare the patient any radiation. And especially in our environment with cost constraints, that may be something to consider. But one limitation of the AMAROS trial is that they did not have an arm with no additional treatment. So we cannot really say what the fate would be of patients who had a positive sentinel lymph node and did not get any treatment whatsoever, as was the case in Z11. Another way of potentially decreasing the odds of an axillary lymph node dissection is by sequencing therapy. And in those patients, if you're going to be using that modality, then all those with a palpable and abnormal lymph node on exam will end up getting neoadjuvant chemotherapy. We know that about 85% of these patients will convert to a clinically negative axilla. And subsequently, after treatment with neoadjuvant therapy, 48% may actually have a pathologic complete response or a path-CR. This is, of course, dictated by the tumor type with the highest response rates in hormone negative and HER2 positive, up to 97%, and lower rates in hormone positive and HER2 negative disease. So what about those who are having axillary surgery after post-neoadjuvant therapy? So in this scenario, anybody that presented with a clinically negative axilla and had neoadjuvant chemotherapy, either for tumor biology or the T size, may undergo a sentinel lymph node. But historically, more than a decade ago, people actually questioned the validity of that procedure. So there was a trial by MD Anderson where they showed that if you do a sentinel lymph node before or after neoadjuvant chemotherapy, the identification for and false negative rates, as well as local recurrence rates, are similar. But one thing we must bear in mind, the difference for the trainees, when you're doing a sentinel lymph node after neoadjuvant therapy, if there is any amount of residual disease, even if it's micrometastatic, you're going to do a completion axillary dissection. So in those who have a clinically positive lymph node and undergo neoadjuvant chemotherapy, after completion of therapy, the axilla is generally reevaluated in different studies. There are different ways of doing it. Some do just an exam and some do an ultrasound. At AKU, we actually do an ultrasound because the predictability of ultrasound is about 70%. And if we find persistent disease, either based on lymph node criteria or persistently palpable lymph nodes, we go straight to an axillary lymph node dissection. But if the axilla is clinically rendered negative after neoadjuvant therapy, a sentinel lymph node may be attempted. But that again raises the question, is the sentinel lymph node going to be reliable when the axilla has been downstaged? So 3 major and well-published, well-talked about trials actually showed that the false negative rate of doing a sentinel lymph node in this setting where they had N1 and N2 disease was slightly higher than the sentinel lymph node that was being done up front. However, when 2 tracers were used, the false negative rate went down. With the greater number of lymph nodes identified, as we know from historic data, that always improves the false negative rates. So by improving false negative rates means it decreases the false negative rate. And additionally, if a clip node, which was a clip that was placed at the time of the biopsy, needle biopsy, if that node was also retrieved, then it further decreased the false negative rate. So if that particular marked or clip lymph node is not identified, then you have a possibility of missing that biopsied node about 20% of the time, which means in other 80% of the time when you're doing the surgery, you will end up identifying it. And in order to mark this node and identify it at the time of surgery, different modalities and different studies have been published, such as the TAD and the MARI trial. And at AKU, we are doing tattooing of the lymph node, which is a pilot study in which we're injecting India ink at the time of biopsy. But more recently, Memorial Sloan Kettering has published their data, where they said without tattooing, without placing a clip in the lymph node, which means without actually trying to retrieve that biopsied lymph node, they were able to identify 3 or more sentinel lymph nodes about 92% of the time using isosulfan blue as well as technetium-99. And in their protocol, they always excise any palpable suspicious lymph nodes. However, a word of caution that this data has not been replicated at other centers, and they actually put that in their own manuscript. All negative sentinel lymph nodes have been spared an axillary lymph node dissection. Thus, about 42% of the time, those that had a path CR were actually spared an axillary lymph node dissection. But at MSK, they excluded all those that had N2 and N3 disease, and the local recurrence rate at 40 months was very, very low at 0.4%. But please do bear in mind that 70% of this subset of patients actually received nodal radiation. So there are at least 2 major trials, and there's also a Taxus trial that I didn't put in the slides that's ongoing in Europe right now. But these trials essentially talk about the post-neoadjuvant patient. So if the axilla has been rendered negative, they're trying to study if additional radiation will be of any benefit. And in the Alliance trial, for a sentinel lymph node that's positive, essentially they're trying to study what Amoros was studied for, which is to see if radiation therapy can be given in lieu of axillary lymph node dissection. So just to summarize, clinically negative sentinel lymph node, in a clinically negative axilla, sentinel lymph node can be performed, and when negative, axillary lymph node surgery can be safely omitted. But in those with low burden disease in the axilla, a lymph node dissection may still be avoided. In a clinically positive axilla, neoadjuvant chemotherapy should be considered, and if rendered negative by neoadjuvant, then a sentinel lymph node may be attempted using strict criteria. If there is residual disease, then a lymph node dissection is performed in this day and age. And I think Alliance and B51 are going to answer some additional questions. I thank you for your attention.
Abda, thank you so much. It gives me great pleasure to welcome Professor Seema Khan to our meeting. Seema was here with us a few years ago, and I was hoping we'll be able to convince her to come this year also, but she was busy and wasn't able to join in person, so she's going to be joining us online. Hopefully next time around, Seema will be able to have you here with us. And I'll wait for that cup of coffee that I need to have with you. Professor Seema Khan is on faculty. She is professor of surgery at Northwestern University, Chicago, Illinois. I asked Seema to talk to us about surgical options in metastatic breast cancer because that was something that I really want to know a little bit more about. And I know that it's sort of like a gray area, and my trainees and my fellows have a lot of questions about that also. So who better than Seema to teach us about what to do surgically for these cancer patients with breast cancer who have metastatic disease. Seema, welcome, and over to you.
Thank you very much, Abdullah and Amina, and good morning to, well, not good morning for you, Assalamu alaikum. It's the afternoon for you. But I'm very happy to be here. And yes, I certainly echo the hope that I will be able to join in person next time. So I'm hearing an echo. I hope you're not hearing an echo. Is the voice okay for you? Okay, well, I'll keep going then. So I'm going to talk about metastatic breast cancer when the primary site is intact. So women presenting with metastatic disease at initial diagnosis. And so here we go. So I have no conflicts of interest. And the size of this population varies across different countries depending on the amount of treatment that's being used. But it can vary from 6% in the US to 20% in many countries where breast cancer is not screened for. The median survival for these patients in 2007 was 40%. In these patients, the intact primary tumor aids diagnosis. It also can allow us to define the biologic subtype, which influences the selection of systemic therapy. However, it can cause symptoms and affect the quality of life. And in 2001, there had been no formal analysis of the value of local therapy to the primary site in stage 4 patients. So we looked at this in the National Cancer Database of the American College of Surgeons for a period of patients that were accrued between 1990 and 93, so a long time ago now. And we found that about 60% of these patients did in fact receive primary site surgery, and that there was a difference in survival, so that women who did not receive surgery had a shorter survival than women who did. This was a retrospective analysis, of course, and therefore subject to selection bias. But in a multivariable model, we found that the hazard ratio for patients who did receive surgery was reduced, particularly if the margins were free. So this set off a whole storm of retrospective analyses from across the world, and many meta-analyses of these studies have been done. I have stopped counting now. There are probably more than 30 studies reported. They continue to be reported. This meta-analysis was published in 2020, I believe, and in 21 was cited by 13 other studies continuing to look at retrospective data for this group of patients. But long ago, I think we realized that this could reflect this association of increased survival with the use of surgery for the primary site could reflect either a consistent benefit across studies and populations or a consistent bias. So selection bias was the main thing that needed to be excluded in terms of accepting these findings of the utility of surgery in stage 4 breast cancer, surgery for the primary site. So the factors that drive departures from standard of care in this setting being no surgery for the primary site. So the factors that drive departures from this standard are the better physiology in some patient groups, such as age and fewer comorbidities, better access to care, better biology of the tumor in terms of hormone receptors, HER2 expression and grade, and a lower metastatic burden. And these biases have been observed and reported repeatedly in all of the retrospective analyses. And they are at best only approximately measured in retrospective data. So all of the retrospective analyses have done adjustments for these biases, but adjustment is only approximate. And the things that we can adjust for are the factors that we can measure. There are many unmeasured biases in retrospective analyses. So we have to turn to prospective trials, which are really the gold standard in terms of addressing these questions. And there are several that have been reported, 4 to be precise. The Japanese study has completed accrual and results are expected at ASCO in 2023. The other 4 have been reported. And they had basically 2 primary designs. In one design, women diagnosed with stage 4 disease received primary systemic therapy and then were randomized to continued systemic therapy or local regional therapy for the primary site only if they did not show any progression at distant sites. And then following the use of local therapy, everyone continued systemic therapy. In the other design, women were registered with de novo stage 4 breast cancer, and then they were randomized immediately to either systemic therapy alone or resection of the primary tumor with radiotherapy, followed by continued systemic therapy. So for the first design, the 2 studies that have been reported were from Tata Memorial in Mumbai and the US-Canada trial, which we reported, I think, a year ago now. And the 2 trials that have been reported with upfront randomization were from Turkey and from the Netherlands, which actually was not reported because it closed for low accrual. And the Austrian study, which was halted early for low accrual, but has been published. So the 2 trials that used systemic therapy first are shown here from Mumbai and from the US. And you can see that there is absolutely no difference in the 2 arms in 3-year survival. There is a big difference in overall 3-year survival between the Indian study and the US study, which is basically related to differences in systemic therapy and access to resources. But between the 2 randomized arms, there's absolutely no difference. So the use of local regional therapy for the primary site did not improve survival in these 2 trials. So then if we look at the upfront randomization trials from Turkey and Austria, the designs are shown here. They were very similar. Again, randomization upfront, and systemic therapy consisted of the usual standard of care systemic therapy that is used for non-metastatic diseases. So there was a difference in outcomes in these 2 trials. This Turkish trial did accrue to their full goal, which is about 270 patients. And at 5 years, they did show an improvement in survival that was, that you can see here, which equaled a hazard ratio of about 0.7. And in the Austrian trial, although low accrual, the group that did a little better was the group that received systemic therapy first, although this was not a significant difference because of their small numbers. So divergent results in these two trials, and much has been made of this result here of improved survival in the Turkish trial. So looking more closely at the two trials that did achieve full accrual, and systemic therapy was provided according to standards of care, including trastuzumab for HER2-positive disease, we should try to identify sources of differences. And one of the main differences is in the randomization scheme. So in 2108, randomization was stratified by important features. In MF0701, there was no stratification. So there were differences in the two arms that favored the surgical arm. So in the frequency of HER2 hormone receptor positive disease, in the frequency of triple negative breast cancer, and among patients who had bone-only metastases, there were imbalances in randomization that favored the surgical arm. And their 3-year survival was 60 versus 51% in two arms at 3 years, and 40 versus 24 at 5 years. In the US trial, it was 70% in both arms at 3 years, and 40% in both arms at 5 years. So if we look at the curves, then you can see that the big difference is the poorer survival in the systemic therapy arm, not the better survival in the surgical arm. So here we see the same 40% survival in both arms of 2108, and a 24% survival in the systemic therapy arm of MF0701. So it appears that the difference in the outcomes of these trials may actually be related to possibly substandard systemic therapy, or imbalanced randomization, or poorer biology in the systemic therapy arm, rather than an actual positive effect of the use of local regional treatment. So there are always questions about subsets, and are there any biologic subsets that do better with the use of surgery for the primary site? And in the US study, we did not see that. The only group that showed some difference between arms was the triple negative group, but this was a very small group with only 20 women with triple negative breast cancer randomized. There are also questions about oligometastases. We had almost 50 women accrued to the trial who had oligometastases with no survival difference across arms. So in terms of local control, the local control was improved by the use of local regional treatment, and this was true of all the trials reported so far. So in the Tata study, you can see the difference in local control here. The local control in the non-local therapy arm was actually very poor in the Indian experience. For 2108, there was also a difference favoring the surgical arm. In MF0701 positive trial, they didn't actually show the curves, but their estimates favored the surgical arm for local control. Did this improve quality of life? That was always the assumption, that better local control would improve quality of life, and that does not seem to be true. It was only really carefully looked at in the Austrian study and in the US study, and we did not see any difference in quality of life, regardless of whether local control was achieved or not. So there are also non-randomized trials that have been published. And there are two actually from Turkey. I'll skip the TBCRC right now because time is short. So this was a study of bone-only metastases, a registry study reported from Turkey following their randomized trial, because the bone-only metastatic group seemed to do better in their analyses. They grouped patient participants by the use of local regional treatment, yes or no. There was no randomization. It was physician's choice or patient choice. The diagnosis of bony metastases was often solitary, but this was confirmed by biopsy in 6% of patients. And there were the usual imbalances between groups that one sees in when randomization is not used, stratified randomization is not used. So also uniformly favoring the group that received surgery. And these are their results, big difference in outcomes based on the use of local regional treatment. But again, the same questions apply to these results as in the retrospective studies, given the imbalances. So if we look at other subsets in this 1401 study, we also see that all subsets did better with the use of local regional treatment. Hormone receptor positive, triple negative, HER2 positive, solid triple metastases. So this improved outcomes in the local regional treatment group are uniform across all subsets, which is also somewhat surprising. And when these data were looked at in a meta-analysis, there was actually no significant survival advantage for bone-only metastatic patients when looking at the results of all trials so far reported. And this was published last year. So from Turkey, there's also been a subsequent multicentric prospective registry study looking at the use of surgical resection at the metastatic site. And there are many questions about this study too. But it's notable that surgical resection was used very frequently in their practice, and liver and lung metastases were resected in the majority of these patients. And the outcomes of this study are that surgical resection of metastatic sites actually is associated with improved survival. Again, similar to results in other studies from the same group. But it's useful, I think, to look at the results of patients who have been entered into randomized trials using local therapy for the metastatic site, so in patients with oligometastatic disease. And this is a recent report from NRG BR002, which was a phase 2 randomized trial. The majority of patients in this trial actually did not receive surgery. They received stereotactic body radiotherapy, so metastatic sites treated with radiation. And you can see the randomization here. In arm 1, symptom-directed palliative therapy as needed and standard systemic therapy, whereas in arm 2, total ablation of all metastases, mainly with radiotherapy. And this trial using radiotherapy did not show any difference in outcomes, in stark contrast to the results of surgical resection that we saw from Turkey. And so I think that those results really have to be questioned. Again, the big difference here is that in the radiotherapy arm, the SBRT arm, the design anticipated a 19-month survival, and they observed a 19-month survival, whereas the design anticipated a 10-month survival in the systemic therapy only arm, and the observed survival was 23 months. So this reflects the continuously improving outcomes that we see with systemic therapy, and I think is an explanation for the negative results of both 2108 and BR002. So in conclusion, I think we can say that the available level 1 data provide little justification at present for a physician recommendation for primary site local regional treatment as a means of extending survival. Although local control is improved by the use of primary site local therapy, so far this has not translated into improved quality of life. And the conditions in which primary site local therapy can be considered, I think, is the rare patient for whom the primary tumor is progressing, but distant disease is well controlled. So this is a group where I do still consider the use of local regional treatment for the primary site. In oligometastatic disease, I think the question has not yet been addressed adequately, and additional trials are needed because this is an ongoing, continuous question. In light of negative trials from BR002, I would suspect that we will not see an advantage even among patients with oligometastatic disease. So thank you again for the invitation, and I hope I did not go too much over time.
Seema, thank you so much. Now for the final talk of this session. This is going to be by Mr. Tapan Sirchar, who's a consultant oncoplastic breast surgeon at the Royal Wolverhampton Hospital in the UK. And he's going to show us some extreme oncoplastic breast surgery techniques. So let's see what's in store for us now in the future.
Greetings from UK. Hello. Greetings from UK. I'm Tapan Sirchar. I'm going to talk about the role of extreme oncoplasty in breast surgery. Extreme oncoplasty, by definition, means breast conserving operation using oncoplastic techniques in a patient who would otherwise be expected to require mastectomy due to their tumor characteristics. Extreme oncoplastic breast surgery is useful in tumors which are large, for example, more than 5 centimeters. For instance, a patient who did not achieve clinical or radiological response to the neoadjuvant treatment, or patients who got extensive ductal carcinoma in situ. It's also applicable for multifocal tumors or multicentric tumors. Traditionally, patients with multiple tumors in the same breast are offered mastectomy with or without reconstruction. But with the modern oncoplastic techniques, we are able to offer breast conserving surgery without taking recourse to mastectomy. For instance, this patient has got multicentric tumor. He has 2 foci of invasive lobular cancer and 1 focus of ADH. The 2 pillars of extreme oncoplastic breast surgery are oncological safety and aesthetic outcome. This is paramount. So what are the options of extreme oncoplastic breast surgery? It could be volume displacement technique based on a superior pedicle or an inferior pedicle, or even round block mammoplasty. And you are aware of the various mammoplasty techniques. It could be volume replacement technique, for example, a mini LD flap, or even a chest wall perforative flap. However, the crucial steps of extreme oncoplastic breast surgery involves accurate staging of the disease with ultrasound, mammogram, or even MRI to know the exact size of the tumor and also the extent of the disease. Adequate preoperative localization of the tumor or calcification with either wire or special tips is important, sometimes to bracket the area of disease. Careful selection of technique is important depending on the breast size, the tumor volume, and the expertise of the surgeon, and of course, the patient choice. Preservation of healthy tissue and careful scar placement is crucial. Maintenance of volume, shape, or symmetry are extremely important. One should always take cavity shape once the tumor is removed, lateral, medial, superior, inferior. This will help to decrease the incidence of positive margin. Intraoperative X-ray specimen should be done in all patients. This gives a guide as to how much we've got clear margins. If there is any doubt, we can always take a little bit of extra tissue. After the tumor has been removed, placement of clips within the excision cavity is important, as this will help the oncologist to give any adjuvant radiotherapy boost if required. Frozen section, where available, is very helpful. So it helps to assess the margins of the resected specimen, and this will again help to achieve clear margin. Accurate pathological assessment of the specimen, goes without saying, is important. A good multidisciplinary team is essential, which includes the surgeon, the radiologist, the pathologist, and an oncologist. So if we were not able to offer extreme oncoplastic surgery, then what are the options? So one could give simple mastectomy or reconstruction, either with implant or autologous-based reconstruction. As you know, implant-based reconstruction can be associated with complication. For example, implant infection in 1 in 4 patients, or implant loss in 1 in 11 patients. And very rarely there is incidence of implant-related lymphoma in 1 in 10,000 to 1 in 20,000 patients. Though rare, it can be extremely significant. Autologous reconstruction can be associated with complication, for example, loss of flap or donor site morbidity. What are the advantages of extreme oncoplastic breast surgery? It avoids mastectomy, and it allows the surgeon to resect a greater amount of breast tissue and reshape the breast and achieve safer margins, acceptable aesthetic results, improve patient satisfaction and cost medicine, less post-op morbidity and post-op pain. And radiotherapy is in fact kinder to breast conserving surgery than to mastectomy with reconstruction. Quicker recovery, less expensive, and often can be done without drains. So here is a patient who's 61-year-old with a palpable mass, measures 90 millimeter mammogram, and the core biopsy shows intracystic papillary carcinoma, which is similar to DCIS. As you can see, the left breast is bigger than the right, but this patient did not want any surgery to her left breast, so she did not want any symmetrization. So this is the marking. We did put a wire. We wanted to make sure that the tip of the wire is where the biopsy was taken, so that we are sure that we achieve clear margins. So this was the marking. We deepitalize around the tumor excision and also around the areola. Here's the resection being carried out. This is post-reconstruction, the cavity. This is a resection specimen, and this is a specimen X-ray. We did take shapes around the tumor cavity, and the tumor, the tissue weighed 192 grams. We're now trying to reshape the breast. We have to mobilize medially and laterally to closure. Post-op histology showed 75 millimeter grade 1 invasive papillary cancer. Margins were clear, ER positive, HER2 negative. As we preoperatively thought it was DCIS, so we had to go back and do sentinel lymph node biopsy, which was clear. Her oncotype recurrence score was low, so she did not require chemotherapy. And this is a post-op result. Good shape of the right breast. However, left breast is bigger. And this is 2 months photograph. And the patient still did not want any symmetrization operation. Is there any evidence of extreme oncoplastic breast surgery? There are several publications. First, explained by Silverstein et al. From USA, and there were subsequent publications in 2019, 20, and 21. And as you can see, the number of patients varies from 40 to 100. The average size of the tumor varies from 50 to 77 millimeters, and the follow-up period varies from 12 months to 60 months. So Silverstein et al. First published a series of 66 patients with multifocal, multicentric, and larger cancers more than 50 millimeters. He was able to achieve clear margins in 83% of patients. Re-excision was required in 9% of patients, and mastectomy was eventually required in 6% of patients. The local recurrence was 1.5% over 2 years. It was good, but the follow-up period was small. So here we can see a patient with a multicentric tumor, and the overall diameter was 8 centimeters. He used 2 wires. He excised the overlying skin. The cancer measured 42 millimeter of invasive lobular cancer, along with ADH, total diameter 82 millimeter, and the margins of 5 millimeter was the nearest margin. As you can see, we had a good cosmetic result. Here is another patient of Silverstein et al. This is a 65-year-old lady with multiple masses on the left side, and better seen on MRI, 9 centimeters. And he used the standard wise pattern incision, 4 bracketed wires. The overlying skin was removed. And as you can see in the specimen X-ray, there were 4 suspicious areas. And the final histology showed 9 invasive foci and a total diameter of 90 millimeter of low-grade DCIS, along with invasive cancer. Margins were clear, and the post-op outcome, the cosmetic outcome, was good. Savilli et al. Published a series of 50 patients from Glasgow and Scotland. 18% of the patients had positive margins and underwent a second procedure. 12% needed mastectomy, and over 5 years follow-up, there was only 2% who developed local recurrence. As you can see, majority, 80% of the patients had wise pattern reduction mammoplasty. Other patients had mastopexy, racket mammoplasty, and Leica flap. 40% of the patients had contralateral symmetrization. What are the effects of radiotherapy in a patient who has mastectomy with reconstruction compared to breast conserving surgery? In the radiotherapy in implant patient has significant effect, causes capsular contraction nearly 50% of patients. It gives poor cosmetic outcome and may require further surgery, for example, implant excision and sometimes conversion to autologous reconstruction. Whereas in breast conserving surgery, there is no deleterious effect of radiotherapy per se. And in fact, the newer studies show that the outcome oncologically is much better. So this study was published from Norway in 2015, and it shows that survival is better after breast conserving therapy than mastectomy for early stage breast cancer. They studied 13,000 women. The 5-year breast cancer specific survival was 97% after breast conserving surgery compared to 88% after mastectomy. This is a study published in 2021 from Sweden. They looked at 49,000 patients, T1, T2, and N02, N2 patients. And they found that the overall survival and the breast cancer specific survival was significantly better after breast conserving surgery and radiotherapy compared to mastectomy with or without radiotherapy. Are there any trials on extreme oncoplasty? So the Alliance trial is being carried out in USA. They recruited 198 patients with multiple ipsilateral breast cancer. 1 out of 4 patients has positive lymph nodes, and 68% had negative margin and got away with only 1 operation. 7% of patients required mastectomy due to positive margins. However, we await the results of the trial, which will give us long-term outcome regarding recurrence and survival. There is a trial going on in UK for multiple ipsilateral breast cancer. So the patients are being randomized into either mastectomy group or breast conserving surgery in the form of therapeutic mammoplasty. So in conclusion, extreme oncoplastic breast surgery is an alternative to mastectomy for large multifocal and multicentric tumors. It is an evolving concept. It extends the scope of breast cancer surgery. The surgical technique depends on the size of the breast, the tumor volume, and expertise of the surgeon, which could be either volume displacement, for example, therapeutic mammoplasty, or volume replacement, for example, chest wall perforator flap. Good preoperative staging of the tumor is important to know the accurate size and extent of the disease. Further operation will be required in small number of patients, for example, re-excision or even mastectomy. So it's important that we counsel the patient preoperatively. Preoperative localization with wires or other localization and device, for example, MAXseed, is crucial to bracket the area of disease. Careful scar placement is crucial for good cosmetic outcome to maintain volume, shape, and symmetry. Intraoperative X-ray of specimen is important, which will guide us to know whether the margins are adequate. Always take cavity shape laterally, medially, superior, and inferiorly. That will help to reduce the incidence of positive margin. Good multidisciplinary team is key, which involves surgeon, pathologist, radiologist, and oncologist. So, in summary, extreme oncoplasty preserves the anatomy, it is oncologically safe, and it gives good patient satisfaction from the studies that we know so far. However, further studies and further trial data is required. Thank you.
Thank you ever so much. If there's any questions, we can maybe take 1 or 2 quick questions, and then we'll just run through a couple of case scenarios, just so that our fellows and residents can see how other institutions sort of carry out their thought process and make their decisions. Hanji.
Okay, my name is Dr. Sadaf. I'm assistant professor in surgery working in Shalimar. My question is with Dr. Abda, Dr. Rafina, and Dr. Amna. It's about the auxiliary surgery. We are not working in a very resourceful environment. We just bought the gamma probe, and thank God in Pakistan now, because you are the ones who knew the struggles we felt when the sentinel lymph node biopsy came, and then the people were not convinced. And now in clinically and radiologically negative axilla, the concept is now accepted that we are going for the sentinel lymph node biopsy. Still, the positive axilla is a kind of threat to the oncologist, and I still have to struggle a lot for them to send me the patients, downstage them, and when and then they are resource limited. We cannot place the clips in them, and we think of doing the India ink or tattooing in them. Then again, the patient selection, then in a resource limited area. I want to ask you guys, what is your center practice? And also what are you doing? Because when the Ceylon Memorial study came out, it was a sigh of relief for me, because they said that there's no difference between the the TAD and without the clinically negative axillary dissection, they are not going for TAD, and they said there's no difference between the two. And for me, then I thought that I could include those patients in my study if they become clinically negative.
Acha, sorry. So the question is कि अगर clinically negative axilla है,
नहीं,
clinically positive axilla है, तो उसको mark कैसे करें?
नहीं, वो तो मैं आपसे दो सवाल हैं। एक तो ये है कि अगर वो क्लिनिकली पॉजिटिव है और आप लोग टैग करते हैं या आपसे नॉन मेमोरियल की तरह कुछ नहीं करते, and then you go for the
Okay, so that's the first question. So if you have limited nodal disease, do we tag those lymph nodes so that we can have those patients go for sentinel node biopsy?
And this,
Okay, let's get the first question for a
Alright,
second. Priya.
alright.
Abda, maybe you could take that.
Sure. So, I'd caution you because when they talk about TAD and MARI procedures, they're putting in a radioactive seed. I don't know if you have that capability. We don't at AKU. And if you're going to put in a lymph node, put in a clip in a lymph node and try and localize it, again, you have to be careful. Some people put in clips, but the clips that have been described in the literature are special clips that are surrounded by gel. That gel swells up when it goes in the patient, and therefore those clips become localizable by ultrasound guidance. If there is no gel around the clip, it is very difficult to try and localize those clips using a mammogram because you just don't get those views, and it's extremely uncomfortable for the patient. Because we don't have those clips that actually have gel surrounding them, therefore we initiated this pilot study using India Inc. because it's still a study and on protocol. So for all practical purposes, for lack of other options, we are using what they do at Memorial Sloan Kettering. We are very aware of the fact that Memorial Sloan Kettering has much higher identification rates than anywhere else reported. So if we don't find clearly 3 sentinel lymph nodes that are either hot, blue, or palpable, we will do an axillary dissection.
All right.
Can I add? I think we are putting ordinary clips in our sentinel nodes. And I must say our clip localization and confirming the clips radiologically before we send it to the pathology, we do that. And I think their identification rate of clip node is definitely more than 90%. And we localize it with ultrasound. So I think, and we are practicing and we definitely will do that. And most of the time we succeed in getting 3 sentinel nodes. And if there is any large palpable nodes that we take out.
Are you using the both dye and the radio?
Yes.
I think it's important. So do teen cheezein important hai. I think one thing is important that every center can develop a protocol of tagging or marking these limited lymph nodes. Now, this can't be done in a floridly positive axilla, right? So this is N1 disease, clinical N1 disease. So there has to be a technique that you are comfortable with, your radiology colleagues are comfortable with, and then whatever mechanism you come up with should be okay. At Aga Khan, they're using the ink, and Rufina uses the clips. We've used clips and we haven't had any problems with localization at the time of surgery. So I think it's just a matter of what you and your colleagues become comfortable with and develop a system to do.
And the second question is that are your initial results matching with the international results in our patients? Initial, what we are also now N1 converted to N0, and you are clipping India Inc. Are the results which are coming are the same kind of results which there is no less rate of local recurrence and possible.
So it's interesting because this is not, so we haven't really been doing it for too long. So we'll have to wait for data to mature in terms of whether these patients have a local, adequate local control compared to the standard of care or not. हमने अपने numbers अभी crunch नहीं किया. I don't know if you guys have actually looked at that.
I think now we are using it for quite some years. I cannot give you the exact numbers, but I haven't seen any obvious local axillary recurrence is a very rare thing otherwise in this select group.
Thank you so much.
Madam, one question.
Sorry, go ahead.
My name is Dr. Ijaz, madam. Madam, sometimes we do get the DCIS component in the wide local excision surgery. The from the margin point of view for the invasive cancer, there is no cancer cells present on the ink side. But for the DCIS, we get sometimes margin between 1 to 2 millimeter. So now what should we do? That the margin for DCIS should be greater than 2 millimeter in such scenarios. Should we go for a little more excision, or no, the principle of invasive carcinoma will be applied in such situation that there is no cancer on the ink margin, so leave the DCIS component.
I think I follow for DCIS more than 2 millimeter. And if there is less than that, I will definitely go back and reshape.
Abda, what do you do?
For me, the most important thing is rad path correlation. So I will always go back, look at the mammogram and see what the mammogram had shown. And if there's any concern that the specimen, based on how I superimpose it in my mind on the mammogram, a lot of decisions are made on that. But for DCIS alone, if the rad path correlation looks okay, then we would want a 2 millimeter margin at our institution.
Okay, so that's interesting. We don't follow the 2 millimeter rule at all. And we've sort of been doing no ink on tumor now for a few years at Shaukat Khanum, and we haven't really seen an adverse outcome in our patients. So I think it's just, again, a matter of what your institution.
But just to clarify, he asked for DCIS, but
Yes.
DCIS we have two,
Yes,
and for
yes.
invasive, it's no ink
Yeah,
on
so
tumor.
for non-invasive
You guys are
cancer,
doing
we
that?
do, yes, we
Great.
don't. do the 2
I routinely take cavity margin shavings whenever I'm doing breast conservation. So in situations where margin is close, but if my margins are, that particular margin is negative, then I avoid further surgeries in those.
And Madam, one more practical question. Sometimes we do get axillary biopsy and we get metastatic carcinoma GATA3 positive favoring the breast primary. But on all the workup on MRI, the mammography, there is no such primary found in the breast. In such scenario, then what should we do? Upfront axillary clearance or neoadjuvant chemotherapy? Then what to do with the
Occult
breast?
breast cancer ki baat kare when there's no breast cancer, but you have axillary disease?
Madam,
Okay.
only metastatic disease is found in the
Right.
axilla,
Right.
GATA3 positive having the breast primary, but nothing in the whole breast.
Right, so occult breast cancer kaise treat ho jata hai?
Neoadjuvant chemotherapy first. Generally, we do an axillary clearance on that, along with a mastectomy, so modified radical mastectomy. There is some data about the possibility of avoiding surgery on the breast and doing radiation along with axillary lymph node dissection, but at our institution, we do an MRM.
Okay.
I think we look at the MRI as far as we are concerned, and there is enough data. If there is occult primary and MRI, do MRI on all those patients. If there is no disease found in the breast on MRI, then doing axillary dissection and doing radiation therapy has also good results, and that's what we practice.
Thank you very much.
Okay, thank you very much. I think we'll just go quickly to our case scenarios. I had prepared 3. I don't think I'm going to have time for 3. So we're going to rush through them a little bit. And for the trainees, please, if you guys have any questions, feel free to ask. Itne sare breast cancer stalwart heroes इकट्ठे नहीं मिलेंगे. Okay, so capitalize on that. आप करोगे लोड कौन सा? Okay, so I'm going to rush through to my favorite case first, and then we'll go back. Okay, so this was my patient that I saw actually some time ago, and there was some interesting decision-making queries, so we're just going to talk a little bit about her, and then we'll go to another case after this. She's a 60-year-old lady who had a very short history of a very small left breast lump that she felt, highly educated, type A personality, quickly made it to us, actually hailed from Islamabad. So on her first convenience just drove over to Shaukat Khanum and said, okay, so this is something that I found a week ago and please do something about it. On examination, it was a very small lump. It was retroareolar, 2 centimeters. One lymph node was a little bit prominent compared to the others. The other side was completely fine, and this is all I found on exam. On her diagnostic workup, on the mammogram and the ultrasound, it was a 4A mammogram, not too suspicious. 1.5 centimeter mass, a little bit retroareolar, kind of swinging to the lower outer quadrant, and one prominent lymph node that they could identify in the axilla. The cortex was measured at 5 millimeters, and it was deemed adequate for FNA, suspicious enough as it was. She actually opted for cross-sectional imaging, so we did a CT and a bone scan, and there were a few paratracheal lymph nodes that seemed a little bit bulky. Apart from that, there were no obvious mets. Now, my question would be now, how many of you, for a clinical scenario like this, which is probably clinical T1, borderline N1, would you do cross-sectional imaging in your institution or just do like a simple X-ray ultrasound?
You want me to take that? So it's an interesting question because we actually looked at our own data retrospectively and we, compared it to the NCCN guidelines. NCCN would recommend doing cross-sectional imaging for something that's stage 3, but in our own experience, when we look at the upgradation or upstaging rate to actually M1 disease, we found stage 2B to be significant. Now, this doesn't even add up to stage 2B. It adds up to stage 2A. So would we do it or not? But for most practical purposes, at least at our institution, we get mostly self-pay patients and they end up dictating care. So whenever there is N1 disease, because there's also a lot of doctor shopping, they'll come see me, then they'll go see Rufina, then they'll go see another person. So oftentimes, just to keep them happy, we will order cross-sectional imaging for that reason alone. But based on data, I don't think it's necessary.
Okay, so yeah, so that's pretty much what we do. But again, owing to her type A personality and what she really wanted is what we ended up doing. And it's interesting. So I have a picture of her mammogram and it's like barely a density that you can make out in the retroareolar segment. Anyway, so she had a true cut. It was a grade 3 invasive mammary carcinoma, 60% ER positive, PR negative. HER2 was positive, Ki67 at 30. And the FNA of that single lymph node that was seen to be suspicious on ultrasound came out to be positive. Let me just ask you guys, in this case, what do you think can be the treatment options जो आप इस patient को दे सकते हैं? When you're discussing treatment care with her, what would you recommend कि ये मरीज करे? हम presume करें कि MDT नहीं है. आपका thought process क्या है? Just one person can answer, then we'll quickly move on. आप लोग खुद volunteer कर लें, नहीं तो फिर मैं pick करूँगी.
So considering her HER2 status positive and lymph node positivity, so we will go ahead with the neoadjuvant chemotherapy. Even then, it is 15 millimeter of PN, but there is a strong indication of being HER2 positivity. So I'll go ahead for this.
Yeah. So
for
interestingly, दो चीजें जो हम consider करें, the ER positive is kind of in her favor. Small tumor size is in her favor, but she is node positive, even though the burden is probably very small, and then her HER2 is 3+ and Ki67 is 30. Rufina, आपका क्या thought process होगा when you're kind of talking to her, guiding her, counseling? Mic on कर लेंगे?
Normally, you say it's for T1C, otherwise also neoadjuvant therapy recommended for HER2 positive. But now with the node positive disease, there's further indication of starting a neoadjuvant therapy.
ठीक है. So we kind of took her through MDT, and they thought that the chunky lymph nodes in the mediastinum were significant enough for her to buy herself an EBUS. And I would say she bought herself an EBUS, which was really not, didn't turn out to be anything, thank God. The other thing that we ended up doing for her was that we did mark the lymph node and we did mark the breast lesion. And I'm going to just put a quick question to you, Abda. When you guys put the India ink in your lymph nodes, doesn't it spill out or spill over to other adjacent lymph nodes through the lymphatics or something?
So there is a little bit of spillover into the fat, but I think that's what makes the identification easy. So it usually doesn't spill over to the surrounding nodes, but the surrounding fat has a little stain
And
on
it stays through the months of neoadjuvant
It
chemotherapy?
does. So that's what we've done. Yeah.
That's so interesting. Okay, so she ended up having chemo, and then she had a great radiological response. And then she came back to discuss surgical options with us. And then, like I said, super conscious, super nervous lady. Surgical options may, what are we thinking? What are we going to offer her? Shuru mein she said, I want to have all options open. I'll make my mind up in 3 months. And she came back 3 months later and she didn't really know what she wanted to do. So how would you take it from here?
So I would do a clinical exam. If there's complete response on clinical exam, I would want to, and that's assuming if she's even considering breast conservation, then we would do a mammogram and an ultrasound to plan localization. For the axilla, again, I would assess the axilla during that ultrasound. And if the axillary lymph nodes have now regressed and show a normal cortical thickness, I would consider that YCN0 and offer her a sentinel lymph node and have a very clear discussion that if I don't find 3 sentinel lymph nodes, honestly, that are either blue or hot, then we'll be proceeding to an axillary dissection.
Would you consider a mastectomy in her, Rufina? It's a central tumor. It's retroareolar. She doesn't have a lot of breast volume. She's node positive, maybe bad prognostic, bad biology disease. Would that even cross your mind when you talk to her?
I think the tumor size to begin with not very large, and it depends on how she has responded to chemotherapy. If there is no evidence of any residual extensive radiological disease, I think one can discuss this with the patient, and breast conservation would be an option here. And unless the patient doesn't want it.
Okay, so we did have pretty much the same discussion that you had, and she did opt to have breast conserving surgery done. The tumor had regressed, the lymph nodes had regressed, and fortunately we had a good response in her. So this was one of my happy stories. We're about 4 years out in her and she's doing great and sends her greetings from Islamabad every so often. So that was good. Just going to go through one more case really quickly. Okay, so it's a young girl, 36-year-old, sitting on a breast lump for many, many months. Mom had breast cancer and survived, but she still decided not to come to us for 8 months, and then came when the lump finally became painful. So a bit sad when she finally made it to us. On examination, it was a small lump, about 2.5 centimeters, middle of the upper inner quadrant. Right axilla seemed to be okay. The other side was fine. And on imaging, she had a 2.3 centimeter mass, 1 o'clock right breast, few cysts, a few prominent lymph nodes, and a small mass which was present in the left breast. Considering everything that's been going on with her, how would you take it from here? I think when we see these patients, it's important that family history, young patients sitting on it for a while, bilateral masses, we have to start counseling these patients in the clinic a little bit to try and make up their mind about what is coming. And this is her mammogram, and you can see the mass, which is a little bit more posteriorly, close to the pec that you can see on this mammo. She had an incisional biopsy done, which we reviewed at our institution. It was invasive ductal grade 2 cancer, strong hormone receptor positive, HER2 negative. The FNA of the lymph node was also negative. And then we did a core biopsy of the left side, and that mass was benign. So additional investigation. So we come back to this. Berka. Genetic testing? Okay, so genetic testing would be really, really imperative in somebody like her. And because mom was treated and was doing well, we did get a BRCA test on her, and her BRCA test was positive. So now with a positive genetic testing result, what are we saying to her? Abda, what would you say to her?
It's a tough discussion with a 36-year-old. What's her marital status?
Married, one child, happy with one child.
Yeah, so I mean, we usually lay out the options of doing, breast conserving surgery versus a unilateral mastectomy versus a bilateral mastectomy. And she's 36, so she still has a little time for her salpingo-oophorectomy, but that's again, we would get her a follow-up with the gynecologist and make sure that we have a good quality ultrasound to rule out any existing masses. And even though there's no data for CA125 definitively, but we end up doing that as well because of lack of data, essentially. So, I mean, what we find very challenging in this subset of patients is to, give them one option or the other, which is better suited to what they want, And because we have the ability to do an MRI and mammogram and monitor them closely, so along with breast conservation, if they can continue to monitor it that way, we're completely happy with it. But we do have a limitation, to the best of my understanding, all over Pakistan, which is, even though we are offering MRI as a screening modality for high-risk screening, I'm not aware of any center that has MR guided biopsy capability. I don't know if you guys have that. You do? Excellent.
It depends on our needles. They come and then we run out, and then we're told, "Kya nahi hai,"
Okay.
and then the next time we want it, then they're like,
So-
"Achha, aa gayi hai." So, but I know intermittently we have done.
Yeah, so that's part of the discussion that we factor in. And of course, we have to keep in mind the fact that the risk of contralateral breast cancer is not as high as getting that primary cancer. So it may be completely okay if she doesn't want to opt for prophylactic, as long as she's committed to contralateral high-risk screening.
Dr. Farooq, मैं आपसे थोड़ा सा पूछूं?
Can I add to this scenario?
Yes, yes.
I think in this patient, probably I will offer her self-injectomy, bilateral self-injectomy, considering her age is 36 and she has one kid. If she agrees with that, I think that would be much, much better than doing a oophorectomy at a later stage. So adding self-injectomy, now we have data that instead of doing a oophorectomy, we just do self-injectomy, and that probably is more protective or equally protective.
Interesting. I was going to ask you that in your setting for these young patients, is it a difficult discussion to have when you're talking about not just a mastectomy for treatment purposes, but for prophylaxis? Because maybe it's a different setting. It's a general hospital. When patients come to Shaukat Khanum, they pretty much have an idea that ye bimari hai, isse deal karna, and it's going to be a tough call. But when they're going to an institution like yours, is it a tough decision to have with them to convince a young woman to have a mastectomy?
Yeah, so this is particularly the reason we went for the surgical guidelines. When I was president of Society of Surgeons last year, we thought this because we had this practice at your center, the specialist centers, and the practice at the general hospitals are a little bit different.
Of course.
Because the patients are different, the socioeconomic status is different, and they cannot come repeatedly. So repeated visits to a radiotherapy for chemotherapy, as Rufina was mentioning, is very, very difficult for the family. So in that setup, I still think that they will prefer for treatment which is shorter and which is more feasible for them. And that's the reason we ask the experts to come and guide the general population, especially our doctors, what to do. So there is a scenario for the resourceful setting, and there is a scenario B for the resource-less setting. And there can't be a scenario for the C-section. So I think that was the fundamental purpose of doing this surgical guidelines, to guide our surgeon as well as our patients, what to do if you have full resources, like you saw Khanum or maybe Khan, but at the same time, if you are in LGH, what to do in that. So what investigations are more feasible? As we know that there is only slight difference, not much difference. So that was the purpose of doing this. So
Yeah, no, I think the guidelines were tremendous. It was really, really a very, very comprehensive guide for people to be able to follow. So that was great. So that's what I figured. Maybe in a situation like yours, in a hospital like yours, where cancer is not the only thing that you're treating, it probably is a harder discussion.
Yeah. Secondly, I believe the shared decision making. I think culturally, treatment has to be culturally correct as well.
Mhm.
So in culturally correct means family is very, very important for our ladies. I think in Sindh, the KPK, the same culture. The decision making is done by the family, right? And for that reason, I think most of the family members are interested in treatment which are short. We don't have to come with the person. So that's why they will go for the mastectomies in that setup.
Rufina, any comments?
I think in a therapeutic setting, yes, they will go for mastectomy. But when it comes to prophylaxis, and when we are seeing now BRCA2 patients and in young patients, it is when even you tell them the probabilities, the figures and risks of conservation versus mastectomy, they generally in a younger patient tend to opt for breast conservation, forgetting the risk and the timelines. And then in young population, it is difficult, and especially if the girl is unmarried.
Right.
But once they are married, they are willing for mastectomy.
So it was very interesting because this patient actually did opt for prophylactic surgery. I don't know whether it was the fact that her mother had gone through this or she never ever wanted to go through this again or whatever. So she did opt for bilateral mastectomies. Now, my question when I do these prophylactic mastectomies is the sentinel lymph node. I don't think I have a right answer for that. I have had patients where I have done the sentinel lymph node, found disease on the other side, and the specimen ended up having like a small invasive cancer. So it kind of gives me a justification for doing it, although the literature doesn't really recommend doing a sentinel on the non-cancer prophylactic side when you don't detect anything. So what do you think about that?
I usually have a conversation with the patient based on the data. There's a 2% chance of finding cancer on the non-affected side based on imaging, and a 1% chance on finding disease in the axillary lymph node. I feel very comfortable not doing, and if the patient understands that, because, in our culture, making them understand is really the challenge. Do I worry about it in terms of the disease? Not really, because if there is clinically occult disease that we're going to find on the sentinel lymph node, it's going to be likely not clinically relevant. So I'm comfortable not doing it as long as the patient is understanding.
So the tumors that I fear to be burnt with are the lobular cancers, I think, and the cases which I have had, in which I've had the contralateral side come up with the tumor have been lobular cancers mostly. Rufina, so if per se you doing a prophylactic side or up sentinel nahi karte or final specimen mein tumor nikal aata hai, small T1D, would you go back for an ALND? Kyunki ab sentinel ki option to rahi nahi hai.
I think this will have
Isn't
a
that
long,
like a big decision.
it's a big decision, but it will require a lot of discussion with the patients and MDT before you take a decision whether what you need to do. But I generally don't do sentinel nodes on the prophylactic side unless there is a pathology radiologically which is suspicious and biopsy does not prove that, then that situation is very different.
Okay, so it's been interesting.
Amna, do you guys do an MRI, or if you're doing a prophylactic mastectomy on somebody with BRCA as a matter of routine?
So for BRCA, we do MRIs. For lobulars, we do MRIs. For ductals, I don't routinely do MRIs for my prophylactic side. Lekin mujhe somehow aisa lagta hai ki maybe I have a bias, so maybe that's what my patients end up doing. But I have done sentinels in the majority of my patients, jinme main prophylactic karti hu. And mujhe aisa lagta hai ki the flipping point comes that when you talk about an axillary dissection, you say, "Acha, ye chance hai," and if the sentinel comes out positive, or if you have a smaller cancer, then we'll have to go back for an ALND. So sometimes, mostly patients will just be like, "Oh, so you're there, and it's not really going to add to morbidity. So it's better ki aap pehle kar dein." But I don't know. I think it's something that I struggle with every time I'm having this discussion with my patients. So, anyways, she did well. She had a bilateral. We put in expanders, and adjuvant treatment ke point of view, say she had an oncotype DX, score was very low, no chemotherapy. Her final treatment was her bilateral surgery, and she's hopefully living happily ever after. So with that, I think we would be coming to an end to our clinical session. Dr. Farooq, मैं आपको थोड़ा सा तंग करूं. If you could just give some closing remarks for everyone who's here and everybody who's listening online.
Yeah, so thank you very much for the opportunity. I think it's a great session, and I really learned a lot. The first talk was from Professor Rufina. So COVID pandemic, and we learned that, yes, a slight delays are not going to impact the overall management of such patients. This was a great talk. Dr. Abda really went through the literature in detail, and she told us about the axillary management. And what I see is there's an escalation, de-escalation overall. I mean, if you see the history of breast cancer surgery, from very aggressive surgeries to coming to lower and more cosmetic surgery. So I think it was a great learning point there. Similarly, we learned that local treatment in metastatic breast cancer from Dr. Seema Khan. We learned that it is not very effective. There's only one scenario in which it was effective when the locally disease is progressing, but the metastatic disease is stable. So that was again a good learning point for us. Well, we are basically extending the limits of cosmetic surgery or aesthetics surgeries. And we learned that extreme oncoplastic breast surgery is also an option now in an expert hands, I think. And that's an evolving concept that would probably be good. And we also learned from the case session. What I want to make 2 points here. I recently conducted as a principal the first SIMSCON, which was basically a research-based conference for my undergraduate and postgraduate. What I found while we were doing this guidelines, that there's a paucity of literature from our own people. So I do a lot of bariatric surgery, and I tell you there is a lot of difference between Asian, Pakistani population and the Western population. So extrapolating data from the American or the Western population, putting it in our own population has a lot of consequences. I think what we need to understand is our own population. And for that, we need to come up with the research. Most of the time we are presenting audits. I think we have to come up and try. There might be different solutions for our own problems. And I think we should come forward in this. The second thing is, I think a few days back, it was a talk in SIMS, and I'm a proponent that as we have Institute for Heart Diseases, we should have Institute for Breast Diseases. At least one provincial headquarters should have Institute of Breast Diseases, because so important. And our daughters, mothers, wives, friends, everybody, they get a lot of suffering. So if they are provided a one-stop facility like we provided for the heart patient, I think it's going to impact their outcomes. In the end, I really thank the panelists, Dr. Safina Sumro, Dr. Abdestar, for joining and for a wonderful session. Thank you very much, Dr. Khanum. Thank you very much for the invitation.